Good afternoon, everybody, our director, and ladies and gentlemen. It is a pleasure to see you all here. Today marks the occasion of 8th International Day of Yoga, and we are proud to be able to host it here at this wonderful place with all of you. I am delighted to welcome our director, all the faculty, students, and staff to celebrate this event. The idea of an International Day of Yoga was first proposed by our Honorable Prime Minister Shri Narendra Modi ji during his speech at the United Nations General Assembly on 27 September 2014, following which the International Day of Yoga has been celebrated annually on 21st June 2015. What we refer to as yoga is a technology to make our energies function by choice, not by compulsion or fixed pattern. Its purpose is to establish a body that is less susceptible to outside influences, a stable platform to build your life upon. Before moving ahead, I request Dr. Gautam Sharma sir to deliver the welcome address.
Thank you. Good afternoon, everyone. So this academic activity marks an important part of the celebration, the week-long celebration that we had for International Day of Yoga at AIIMS. This is an initiative of the research department, especially Dr. Vineet Ahuja and the mentorship of Dr. Subrata Sinha. And it's really an important activity in the sense that it's going to encourage more and more AIIMS fraternity to come forward and generate scientific evidence for yoga. As she mentioned, it's a technology, and we need to really evolve, and we need to search, and we need to find out ways in which it's going to help people in various disease states, and of course in health. So for those of us who witnessed the morning celebration, the mass yoga, would vouch for the fact that yoga is gaining popularity amongst the AIIMS staff, AIIMS family, and AIIMS fraternity. Similarly, going by the papers that have been submitted today for this competition, academic competition, more than 80 posters have been submitted. So you can judge that it's yoga research is a popular theme amongst AIIMS faculty. So I think I would just stop here, and I would welcome the director, Dr. Randeep Guleria, for gracing the occasion, Dr. Subrata Sinha, the chairperson of this academic committee, our MS, Dr. D.K. Sharma, the Dean Academic, ma'am, Dr. Neena Khanna. So, and most importantly, all the participants who have participated so enthusiastically in today's competition. So good luck for all of you. And so I hand over to you now.
Thank you, sir. Now I invite Dr. Subrata Sinha to tell us about research in yoga at AIIMS.
Thank you very much. And I'm really pleased that today we have initiated a yoga day on the International Day of Yoga, a showcasing of the research on yoga at AIIMS. And I must say, I am very sure that it will become an annual event. And what it does is it will bring up various arms of the yoga fraternity, the yoga science fraternity together to celebrate both yoga and science. So when we look at the science of yoga, I mean, initially for a person like me, who initially had not much of a concept about yoga, to be fair, except for what a general person thinks, apart from having practiced a little bit of yoga for a year or two on a regular basis. But sometimes I was kind of forced to think about how do you talk or think about science and yoga together, because yoga is an ancient system. There is a science behind it which perhaps we very often need to rediscover and reappreciate, and we have our own scientific method of looking at things. So once we were deciding how do you judge a good project on yoga, for example, there was this group of science and technology of yoga and meditation, of which I was, in a way, accidentally pushed into chairing. So, what the methods that we evolved was one, of course, does we would like to measure yoga by the same methodologies and the same rigor that we use for any other science. So, in a way, we are stripping yoga in our scientific method of its spirituality and the other aspects of belief which go on with it. So we are not, while we don't look at yoga exactly as a physical system, we are measuring yoga at the physical level when we look at yoga and science. Physical means anything which can be measured, including molecular and all that. So what do? We look at study design. Which I'm sure all of you have looked at with great rigor. We look at measurability, we look at reproducibility, and then we apply the same standards of evidence for effect and for long lasting effect that we would use for any other science. The other thing that we do is, which in this institution, which I would appeal to you to do more and more. I know I have seen a lot of lovely posters on yoga, and starting from epigenetics to autonomic nervous system to electrophysiology studies. But please use the huge depth of human ability, our ability to measure phenomena at the cellular, systemic, as well as whole or individual level that we have in our institution. And more, the novelty, the sophistication, and perhaps, move in a way beyond what we are doing is correlation and causality and effect, move beyond that also to what is known as mechanistics. So, how does yoga affect your epigenome? What is it in yoga that makes your epigenome pliable? What is it that in yoga that affects your autonomic nervous system? What is it that creates a difference in functional MRI if you have undergone a yoga protocol for a fixed period of time? So this is something, this is where the novelty comes in, and this is where the frontiers of science are on one hand. On the other hand, I am very happy to say that the clinical research unit is already, which is a part, AIIMS is affiliated to the Cochrane system, and a clinical research unit is kind of its, let me say, nodal body for that. And they are already in the process of producing an evidence base of yoga based on Indian Cochrane and other models, so that tomorrow we can actually synthesize and collate the evidence not only from ourselves but worldwide, and really produce a definitive works on, based on class 1, 2, 3 levels of evidence which Cochrane uses, and which is also acceptable worldwide for the efficacy of yoga, and then move further on to biomarkers and susceptibility studies and so on and so forth. So for this, I'm so happy that the people who do science of yoga have put forward such a wonderful feast of science. Thank you very much.
Thank you so much, sir. Now I would like to invite our Honorable Director, Shri Randeep Guleria ji, to say a few words.
Thank you. Good afternoon, and once more, my best wishes on this International Yoga Day that we're celebrating, the 8th International Yoga Day. And considering the fact that this is our 75th year of independence, I think there can be no better way to celebrate it than to show the research that we're doing as far as yoga is concerned. The All Institute of Medical Sciences has always been known to be really leading as far as research activities is concerned. And we have been doing that consistently for so many decades. AIIMS has always been rated number one as far as research in the medical field is concerned. And therefore, it's no surprise that such a lot of research, both from the point of view of clinical outcomes at a molecular level and even to some extent looking at the mechanistic level, is being done at the All Institute of Medical Sciences on yoga. Yoga is a science and an art. We know the art of yoga, we know the spirituality behind yoga. But I think AIIMS is the best place where we can unravel the science behind yoga. And that can be done here because we have such a bright group of researchers, inquisitive, willing to think outside the box, and willing to really go that extra mile when it comes to doing research. The researchers here are willing to spend the night in the lab, work over weekends, just so that that research can reach that high level of quality that is needed. So I think it's a factor that plays a huge role in what AIIMS is today in terms of research. Also, I think it's important for us to understand that we've come a long way in this journey of science and yoga-based research. When yoga-based research was done, it was started in Department of Physiology also a long time back. It was a big challenge to do research on yoga. You didn't know where to get someone as a good yoga instructor. Remember, I think it was in the 90s that we did a project with Department of Physiology looking at autonomic function and control of asthma using yoga. And the yoga instructor actually used to come from Chhatarpur Mandir. He used to come here, he would do the sessions, and we had this whole group of asthmatic patients who underwent yoga. And then Department of Physiology actually looked at the function. And I still remember that yoga instructor who was in Chhatarpur Mandir, who was so impressed by the results that he bought a portable spirometer for his ashram so that he could do spirometry for all his patients there and document the improvement that was happening in lung functions because of yoga. So he came and met me many years later that I now have a huge database of lung function pre and post yoga exercise in a large group of healthy individuals and individuals with some degree of illness. From there, we've come a long way. I remember almost 10 years ago, I did a project looking at a randomized control trial on yoga-based rehabilitation as compared to standard pulmonary rehabilitation in COPD patients. And we even looked at inflammatory markers and showed that yoga actually was more cost effective and caused significant decrease in inflammatory markers, a 12-week protocol. There again, we had that issue of how do we get a good yoga instructor, and it had to be factored into the project, and we had to really you have to really look for a yoga instructor. From that time to now having a center which is doing so well, the CIMR under the leadership of Dr. Gautam Sharma is remarkable. We have come a long way, and now we have a vibrant research environment as far as yoga is concerned, with so many departments working together, collaborating, and with a lot of support from CIMR as far as yoga-based research is concerned. And I think that is reflected in the posters, in the presentations that you see today, because I think what has really changed is the activity that has been done by CIMR. And I think they really deserve a round of applause for this great work that they're doing. We are not a yoga institute. We are the All Institute of Medical Sciences, which does a lot of other things besides yoga. Yet, I think I can say confidently that probably the diversity of research and the type of research in yoga that we're doing today is probably the best and of the highest quality in the country. And I think that is something we should be proud of. So it's a proud moment, and I sometimes feel we should showcase what we're doing to the world, to the country, that this is the type of research AIIMS is capable of, and this is what we're doing, even in the field of yoga, which is not our primary area. We do academics, we do patient care, and then we struggle to find time for research. Despite all of that, we're still managing to do such excellent work. So I would really like to congratulate each and every researcher, each and every person who is part of the research team, whether his name is on the paper or not, but he who has contributed to that, for the excellent work that they've done. This is a commitment that is there. Research is not easy. You have to coax your patient. And when you're doing research on yoga, you have to have a follow up. You have dropouts. You have the challenges of the pandemic. Very often, you have to change your treatment strategy from physical to virtual yoga training programs. Despite all of that, we have managed to have such a lot of good publications, such a lot of good research on yoga. And I'd like to congratulate you all for that. So I would like to just say that we should all be proud of the work that we're doing. We need to showcase it. We need to show the world how much work we're doing. And I think it's a great achievement for the Institute. So from my side, thank you very much for all the research that you're doing. We're really proud of you. Thank you.
Thank you, sir, for your kind words and for always encouraging us. We now begin with the oral presentations. 6 best abstracts have been chosen for the same. The time awarded for each presentation is 7 minutes plus 3 minutes extra for discussion. I invite Dr. K.K. Deepak, Dean Examination, Head of Department Physiology, and Dr. Subrata Sinha, Dean Research and Head of Department Biochemistry, to chair this session. First presentation is by Dr. Surbi Gautam, titled as Yoga Re-establishes Immunological Tolerance and Reduces Severity of Comorbid Depression in Active Rheumatoid Arthritis. Professor Reema Dada is corresponding author.
Thank you very much for being here. And we begin with the scientific session. Out of 92 posters, the judges have selected 6 best posters for the oral presentation. The rest posters are others. There were 10 selected from poster presentation. So these are the one of the 6 posters, one of 6 abstract which was submitted, which is being presented. So I go over to the presenter. Dr. Surbi will present the case. You have 7 minutes to present. We'll cut short otherwise. And there'll be 3 minutes for presentations, questions, answers as well. Thank you. Thank you. Time begins now.
Good afternoon, everyone. The title for my presentation is Yoga Re-establishes Immunological Tolerance and Reduces Severity of Comorbid Depression in Active Rheumatoid Arthritis, a randomized controlled trial. Rheumatoid arthritis is the most common inflammatory arthritis. Rheumatoid arthritis is the most common inflammatory arthritis with systemic and articular manifestations. Premature immune aging, oxidative stress, and mitochondrial dysfunction has been implicated in the pathogenesis of rheumatoid arthritis. The patients of rheumatoid arthritis, they exhibit comorbid depression, anxiety, and stress. That's why they have a dysregulated psychoneuroimmune axis, and hence mind-body interventions like yoga has become the need of an hour in this era of super specialization, as this disease is having a psychosomatic component. Various studies have documented the beneficial effects of yoga on clinical symptoms, quality of life, psychosocial outcomes, pain equity, functional abilities, and sleep patterns. However, the current evidence is limited regarding how yoga practice affects systemic biomarkers of inflammation, mitochondrial health, immune aging, especially in rheumatoid arthritis. So, the aim of this study was to assess the impact of yoga on immune aging, mitochondrial health, disease activity, and severity of comorbid depression among RA patients. So we assessed 110 patients, and out of which 24 were excluded, and remaining 86 were randomized into two groups, yoga group and non-yoga group. Yoga group received the yoga-based lifestyle intervention along with the usual care drug therapy, and the non-yoga group received only the conventional disease-modifying anti-rheumatic drugs. And the baseline measurements were obtained at day 0, and the post-intervention measurement was obtained after 8 weeks of intervention. So this is the table which shows the list of activities in a single session of yoga-based lifestyle intervention. And these are the pictures which we have taken when the patients were performing certain asanas. Following systemic and clinical parameters were analyzed, which I shall be discussing one by one. Now coming to the results, first of all, we have estimated the effect of yoga on inflammatory markers. And we have seen that there was a significant reduction in acute phase reactants in terms of reduction in ESR levels and CRP in the yoga group as compared to non-yoga group. Then we have seen a significant decline in pro-inflammatory markers. The important pro-inflammatory markers studied were IL-6, IL-17, and TNF-alpha. Then we have studied the anti-inflammatory markers like TGF-beta and immune regulatory markers like soluble HLA-G, which have shown a significant upregulation after yoga-based lifestyle intervention. Then we were interested to know the effect of yoga on T cell population, as there is Th17 T regulatory cell excess dysregulation in RA patients. So we were interested to see the frequency of Th17 population. So this is the flow diagram which shows the single patient pre and post yoga, and we can appreciate the Th17 cells, the percentage is dropping down from 1.39% to 0.5%, and also the aged T regulatory cells, they were also showing a decline. So cumulative effects of these flow cytometric analysis showed that Th17 population is significantly downregulated in yoga group as compared to non-yoga group, along with aged Th17 cell population. Then the change in T regulatory cell population, we have seen the significant upregulation in the T regulatory cells, and along with that, there was a decline in aged T regulatory cells after the yoga-based lifestyle intervention. Then we studied the effect of yoga on gene expression patterns, and we have seen the genes associated with inflammation, and the genes associated with inflammation like IL-6, TNF-alpha, CTLA-4, CXCL2, CXCR2, they have shown a significant downregulation in the yoga group after yoga-based lifestyle intervention, and also the transcripts associated with mitochondrial integrity, biogenesis, and architecture, they have shown a significant upregulation. Then we have studied the markers of oxidative stress and cellular health, and we have seen that yoga optimizes oxidative stress levels, as was seen by the reduction of reactive oxygen species, increased total antioxidant capacity, and reduction in the 8-OH-DG levels, which is a DNA damage marker. And then we have seen the upregulation of telomerase activity, and we can also appreciate that yoga aids in maintenance of telomere length. Then the effect of yoga on mitochondrial integrity. We have seen that yoga improves mitochondrial health, as it was seen by the increased levels of NAD, COX-2 activity, and mitochondrial copy number, and also the increase in the mitochondrial membrane potential. Then we studied the markers of neuroplasticity, and we have seen that BDNF, which is brain-derived neurotrophic factor, beta endorphins, and DHEAS, they all show a significant increase after yoga-based lifestyle intervention. And these markers, they also change the brain anatomy and maintain the and tend to maintain the uh, resilience also. And then we have studied the circadian rhythm markers, and we have seen that there was a down regulation in circadian rhythm markers and in terms of cortisol, and increase in melatonin levels, which is a potent antioxidant and anti-inflammatory marker. Then we studied the effect of yoga on clinical parameters. And in clinical parameters, we have studied the pain acuity by visual analog scale, depression severity by BDI-2 scales, and disability index by health assessment questionnaire, and disease severity by disease activity score, which was estimated by clinicians. And then an overall improvement was seen in the quality of life, which was assessed by WHO quality of life BREF questionnaire. So to summarize, yoga aids in regression of inflammatory processes by reducing pro-inflammatory cytokines and increasing anti-inflammatory cytokines. And yoga in active rheumatoid arthritis patients normalizes dysregulated transcripts, maintains Th17 T regulatory immune homeostasis, optimizes oxidative stress markers, improves mitochondrial integrity, reduces the rate of cellular aging and increases cellular health span, improves neuroplasticity. It normalizes circadian rhythm and reduces pain perception and depression severity. Along with that, disease activity scores, and hence improves the quality of life. So, dysregulated immune response, accelerated immune aging, DNA damage, oxidative stress, psychological stress are all modifiable factors which impact disease progression. And these are all the targets of yoga, and no single treatment modality in modern medicine alone can impact all these factors. So, yoga possesses immune modulatory potential and reestablishes immunological tolerance and molecular remission, and hence can be beneficial as an adjunct therapy in the management of this severe autoimmune disorder. Thank you.
There is no question. If there is any question from the audience, please come up. From the audience, I'm just curious, what is it in the process of yoga or the asanas that you do will finally manifest itself in, let us say, change in numbers of Th17? Have you, I mean, I know it's very difficult to study, but have you thought about it?
Sir, actually, when a person does pranayam or loosening practices or regulated breathing or dhyana, then the body of that person undergoes a meditative state of bliss, and then he or she may experience a reduction in inflammatory cytokines, and that inflammatory cytokines, the
No, I
environment of
agree. But the bridge between meditative bliss and inflammatory cytokines, if you have to bridge that bridge, how would you like to do it? Are you getting my question? That's okay. It's not an easy question to answer. I wouldn't know it myself, but it's something to think about.
We can take
Show that if you have restrictive eating and all, then there is a little bit of lymphopenia. And the first population which comes out is the T regulatory cell. So if the T regulatory cells are going to increase, the Th17 is possibly going to come down.
Sir, actually the environment which is created by the environmental milieu, which is created by the cytokines present around these cells, so they tend to, the cells tend to behave like that. So this state of bliss, it acts upon the systemic biomarkers, and then they ultimately change the T cell population.
So, yeah.
Yoga has multiple segments.
Yes, sir.
Which part plays a dominant role?
Yes.
Sir, I think
Meditation, is it the
Sir, I can't comment like which one would be more effective. It acts as a whole, like asanas, pranayam, and dhyana.
So I think I would like to take from here. It's a very difficult to answer. Follow the all principle of reductionism.
Yes.
The first thing today I would believe, working for 30 years, not to use the bliss on this until you define it. The problem is that we use so many words which is difficult to define in the laboratory situation until it's quantifiable. Therefore, we have to do a lot of research. You have to do a lot of research
Yes.
when you come to the conclusion of
Yes.
which particular component. So
Yes.
thank you so much. We can again clap for this presentation.
Next presentation is by Dr. S. Edmund Krista to present her work titled Effects of Yoga-Based Cardiac Rehabilitation on Left Ventricular Ejection Fraction and Central Hemodynamics in Patients Post-Myocardial Infarction. Dr. K. Deepak is the corresponding author.
It's not coming. It's not coming actually. Okay. Good afternoon, everyone. Myself, Dr. Prachi Srivastava, and I am here to present this work on behalf of Dr. S. Edmund Krista. So the title of the study is Effect of Yoga-Based Cardiac Rehabilitation on Left Ventricular Ejection Fraction and Central Hemodynamics in Patients of Post-Myocardial Infarction, and this is a randomized controlled trial. So as we know that presence of acute myocardial injury is the leading cause of death among ischemic heart disease, and the left ventricular ejection fraction is the most widely used index for the evaluation of left ventricular contractility function of the heart and is an independent predictor of cardiovascular and all-cause mortality. Similarly, central blood pressure has been shown to be a superior independent predictor of future cardiovascular events than the peripheral blood pressure. So the study's aim was to evaluate the effect of yoga as an adjuvant to standard care on ejection fraction and central hemodynamics in patients of myocardial infarction. And to fulfill this aim, 80 patients with myocardial infarction were included in the study. Patients of acute myocardial infarction within the duration of 1 month and willing and able to attend complete hospital-based yoga, cardiac yoga rehabilitation program were included in the study. And the patients who were considered ineligible if they were regularly practicing yoga more than 3 hours in a week and had any other disease which limits their life expectancy less than a year based on clinical records were excluded from the study. So, for assessing central aortic blood pressure was used to assess central hemodynamic parameter, and for measuring central aortic blood pressure waveform were recorded from radial artery using the sphygmocode device, which is basically a tonometer device. And for calculation of central aortic blood pressure, recorded radial artery waveform was used using the transfer function analysis, which is the inbuilt features of sphygmocode device itself. For left ventricular ejection fraction was measured by M mode and two-dimensional echocardiography by a cardiologist using standard recommendation. Now, this is the intervention protocol. So, the yoga intervention protocol consisted of 13 yoga session and which is the complete hospital-based yoga session. And this yoga intervention was given by a professionally trained yoga instructor. So the initially two sessions were given individually, and so the session from 3 to 13 were given in a group. And from 13 weeks onward, the patients were instructed to follow these sessions at home. And for that, booklet and video audio recorded CD was provided to each patient to follow this session at home. And this exercise come education session included combination of different breathing exercise for physical fitness, stress and relaxation, which included meditation and relaxation. While on the other hand, the standard care group received three educational advices session in the hospital along with the printed leaflet before discharge at 55th week and at 12th week as an adjunct to routine clinical practice of providing drug and treatment. Now, this is the structure of single yoga session. A single yoga session was around 1 hour 15 minutes, which included a combination of different simple to complex yogic posture and different control breathing exercises followed by meditation and relaxation. This is the patient flow diagram of patient follow-up. So this study was sub-study of multicentric clinical trial, which was held in AIIMS, and the randomization was done by following a interactive web-based response system, which was developed and maintained by CCDC. So total 80 patients were randomized in yoga group and standard care group based on the randomization protocol, 40-40 in each groups. And the test was done at baseline, which is the 3rd week, followed by 13th week and 26th week, and in both the groups. So the loss to follow-up was more in yoga group compared to standard care group. So total 18 patients were completed all the follow-up and all the session and practices in yoga group, while the final number of patients who completed follow-up was 32 in standard care group. There was two kind of analysis were performed to analyze the data. One is the per protocol analysis was used to analyze the exact number of patients who completed the follow-up, and intention to treat analysis was used using 40-40 patients in each group. So now moving on result part. So the results are expressed in mean plus minus SD of the delta change between the 13th to 3 week and 26th to 13th week. And central aortic diastolic blood pressure was significantly decreased in yoga group compared to standard care group, and there was no difference observed in systolic and pulse pressure, and all the parameters were comparable at baseline between both the groups. Now this is the graphical representation of aortic diastolic blood pressure. So in both the analysis, intention to treat and per protocol analysis, there was a significant difference between the group in aortic diastolic at 26th week, and during this follow-up period, central aortic diastolic blood pressure decreased in yoga group as compared to the rise in the standard care group at 26th week. Now moving off left ventricular ejection fraction result, there was a significant increase in left ventricular ejection fraction in yoga group, while a decline was noted in the standard care group. And this increase in left ventricular ejection fraction in the yoga group was more pronounced than in standard care group at 26th week. So the study concluded that addition of yoga-based cardiac rehabilitation to standard care facilitate greater recovery of myocardial function as measured by left ventricular ejection fraction, and this may have important prognostic implication in the patient recovering from myocardial infarction. Thank you.
Yeah. Anybody would like to ask any question? We have a few minutes. Yes, please.
What was the baseline ejection fraction for these cases?
Ma'am, it was comparable in both the groups.
Like, what was it? Because
Now, the baseline ejection fraction in most of the cases around 50 somewhere. Thank you.
Any more any more questions? Anybody wishes to ask any question? Okay, if there are no more questions, I just have a little bit of a doubt. There are, I think, cardiologists have standard non-yogic practices of cardiac rehabilitation as well, which are not commonly administered in our hospital. So, would you like to use that as a control arm and then study yoga?
Maybe it is possible, but for this
No,
chapter,
so this is fine, but eventually, because you have to bounce your therapy against what is the sort of mainstream hardcore cardiologist's prescription,
yes,
that way.
yes,
This
sir.
is very useful.
Yes,
It's
sir.
definitely because most of people are not getting that standard cardiac rehabilitation, which the cardiologists say. But anyway.
Which was noticeable in a study, it's a great study, was that your people, the non-compliance rate was very high. That in the sense that your intention to treat analysis, you had
Yes.
40 in 18 patients. Per protocol, you had 40. Like there's a vast difference. So
Yes,
do you
sir.
think when you're going to subsequently advise this kind of intervention, do you think that would be a stumbling block? Or is it that we are advising too many intense yogic exercises, and can we have a step down, something like partial intervention? Because the compliance rate is really poor.
Yes, sir. Yes, sir. So, sir, basically for like clinically advice, so obviously a large scale study would require that. And yes, the compliance was very high in the yoga group. There was a lot of loss to follow up. That's why intention to treat analysis was performed.
What Dr. Vineet is saying that instead of that 1 hour, 15 minute or 1 hour yogic protocol, if you say something like half an hour, maybe people cannot.
What is too severe?
Yes, yes. Yes, yes. To simplify the protocol, basically.
Too much to expect every day.
So it was difficult, we know, with the other, some of the limitations. Thank you. Thank you once again.
Next poster is by Dr. Kirandeep Kaur, titled Effectiveness of Yoga Meditation for Adults with Epilepsy. Dr. Manjri Tripathi is the corresponding author, and as she is unavailable, it will be an audio-visual presentation.
Audience members, today I would be presenting the study entitled Effectiveness of Yoga Meditation. Good afternoon, respected audience members. Today I would be presenting the study entitled Effectiveness of Yoga Meditation for Adults with Epilepsy, a randomized controlled trial. This study was designed and conceptualized in the Department of Neurology under the guidance of Dr. Manjri Tripathi. The study was a part of my PhD thesis, and it was implemented in collaboration with Center for Integrative Medicine and Research under the guidance of Dr. Gautam Sharma. So, as we all know, epilepsy is a disorder characterized by recurring episodes of paroxysmal brain activity due to sudden, disorderly, and excessive neuronal discharge, resulting in what we commonly call seizures or fits. But epilepsy is not just about seizures alone. Persons with epilepsy are often afflicted with very debilitating comorbidities such as stigma, anxiety, and depression, which have a consequent impact on their quality of life as well as seizure frequency and other clinical outcomes. On the other hand, it is very well established in the medical literature that the psychosocial burden of epilepsy is a highly prevalent and recalcitrant problem all over the globe and remains as such because there are very few interventions which have been studied as efficacious methods of rehabilitation for persons with epilepsy. Previously, very few studies have studied the effect of yoga and or meditation on clinical and psychosocial outcomes in epilepsy. One such pioneering study was conducted in AIIMS itself by Dr. K.K. Deepak. However, to the best of our knowledge, this current study which is being presented here is the largest placebo-controlled RCT to study the effect of yoga and meditation on neuropsychiatric and clinical outcome in persons with epilepsy. The defined objectives of the study were as follows. The primary objective was to compare the efficacy of an integrated yoga meditation plus psychoeducation module with sham yoga plus psychoeducation module to decrease the epilepsy-related stigma in persons with epilepsy in India. The secondary objectives were to compare the efficacy of these interventions in reducing seizure frequency and improving depression, anxiety, quality of life, cognitive impairment, mindfulness, emotion regulation, and EEG power spectral density in persons with epilepsy. Methodology. This was a randomized, controlled, two-armed, double-blinded trial where both the patients as well as their caregivers were blinded to the treatment allocation. The sample size consisted of 80 cases plus 80 controls, taking it to a total of 160 patients. The randomization was stratified on the basis of seizure frequency. Group A consisted of patients whose seizures were controlled for 1 year or more on adequate medication, while Group B consisted of patients whose seizures were not controlled on adequate anti-epileptic drugs. The stratification was done in the ratio 1:1, that is, each group was allotted 50% weightage. Our population, according to this P-chord diagram, consisted of persons with epilepsy who scored greater than 4 on the Kilifi stigma scale. This is a validated and well-accepted measure of epilepsy-related stigma. The intervention consisted of an integrated yoga meditation module whose details are discussed in the upcoming slides, plus psychoeducation module. The comparator arm consisted of a sham yoga protocol, again whose details are explained in the upcoming slides, plus psychoeducation. The outcome measure, the primary outcome measure, was significant change in the stigma score, and the time points were 3, that is baseline, 3 months and 6 months follow-up. This yoga meditation module was prepared in consultation with experts from CIMR, AIIMS and S. Vyasa University, Bangalore. The inclusion criteria consisted of patients who were consenting, diagnosed as having epilepsy based on the ILAE criterion, age range of 18 to 60 years, and again scoring positive on the Kilifi stigma scale. We excluded patients who were non-consenting, had any other confounding, significant physical or cognitive disability, or they had been previously practicing yoga meditation for a period of 3 years or more prior to enrollment. The yoga meditation module explained here was conducted in a series of 7 supervised sessions conducted over a period of 12 weeks or 3 months by certified therapists. It consisted of roughly 5 minutes of Sukshma Vyayam or loosening practices, 10 minutes of pranayam, and roughly 15 minutes of meditation in Shavasana. The sham yoga group were given exercises that mimic the yoga asanas, but they were devoid of 2 key components of yoga, which is slow and synchronized breathing and body awareness. This group was introduced to the concept of yoga in the same manner as the intervention group, but they were given exercises which only mimic the yoga asanas but were devoid of the key components which make up yoga. The results of this trial are summarized in this consort chart. 456 participants were assessed for eligibility and 160 were randomly allocated to the intervention or control group. At the end of 3 months, 10 patients in the control group and 8 in the intervention arm were lost to follow up. 7 more patients were lost from both the groups at the end of 6 months, taking the total for per protocol analysis to 66 in the control group and 69 in the intervention group. This slide gives a diagrammatic as well as a tabular representation of the primary outcome, which is the Gillespie stigma scale. As we can see from the table, at the end of 3 months, the intervention group showed significant differences in stigma scale as compared to the control group, and the effect size for the same was 0.353, which is considered mild to moderate. According to per protocol analysis, we saw significant differences for the intervention group at both the time points, that is 3 months and 6 months. Coming to the clinical outcomes, this slide shows the proportion of patients in both the intervention and control group who had greater than 50% or 90% seizure reduction or complete seizure freedom at the end of 3 months and 6 months. As can be seen from the charts, there were significant differences between proportion of patients who achieved greater than 90% seizure reduction or complete seizure freedom at the end of 3 months as well as 6 months. The mean percentage change in seizure frequency at the end of intervention period or study period, which was 3 months, was 21.2% in the intervention arm versus 5.1% in the control arm. This slide shows results of selected secondary outcomes, specifically depression, anxiety, quality of life, and Montreal Cognitive Assessment, which measures cognitive impairment. All significant differences between the intervention and control group have been highlighted by an asterisk. For PHQ-9 or depression, we saw significant differences at the end of 6 months. Quality of life differences between the intervention and control group could be seen at both time points, that is 3 months and 6 months, while those for cognitive impairment could again only be seen at 3 months. For GAD-7 or anxiety, we did not see any significant differences between the intervention and control group at any time point. All of these results are for ITT or intention to treat analysis only. In conclusion, the intervention group reported significant improvement in depression, cognitive impairment, mindfulness, and quality of life as compared to the control arm at variable time points. Yoga and meditation can significantly improve the overall quality of life in epilepsy by improving the neuropsychiatric and clinical outcomes in epilepsy. Most importantly, this therapy was easily disseminated, cost-effective, and efficacious in managing the overall burden of epilepsy, which still remains largely unaddressed in Yes.
If you please explain once again the sham yoga, how it is different from the yoga.
Yes. Am I audible? Yes. So the idea was for sham yoga was like I'm just explaining why the concept was introduced in the first place. Believing that you are doing yoga should not have an effect on your outcomes. And if that's the case, we should know that it is not that yoga is creating an outcome. It is just that because you're being given an intervention or you're just being given attention under therapy, that's why you're getting well. So if I've just explained where we are coming from, that it's not like we are just because a therapy is being given and believing that you're being given a therapy should not impact the outcomes. And if that's the case, we wanted to control for it. So the idea of sham yoga was to make the patients believe that they are being given yoga therapy, but it was devoid of the key components of yoga, which was discussed, with experts from CMR. Two of these components were that there has to be a synchronization, slow and synchronized breathing. That is, the movements, the hand movements or the movements of the body should be synchronized with the breathing patterns. And the second is the awareness, the body awareness. You should be in the zone, you should be mindful of what you're doing. So these were conceptualized as the key outcome, the key components of yoga. And if we devoid yoga of these two components, the breathing and the mindful awareness, then it is equivalent to any other physical exercise. So if I'm talking about the loosening practices, if I'm just opening and closing my fist, the metabolic, it is the metabolic equivalent of doing yoga. So it's like an exercise, but it is devoid of the components which are relaxing, which relieve us of stress, and other components which have beneficial effects, say on the HP axis. So this was the whole idea of doing. So this was the essential concept of sham yoga. It has been there are at least 2 or 3 studies which have implemented a similar technique of sham meditation and yoga, not in India, but from other groups in California who have done that. And we wanted to do something similar for our study. So that's how it was conceptualized, and this is why it was designed.
Yeah, you are right. But I think still this sham yoga versus yoga, it needs review. Because in my opinion, what you are saying is more of based on the beliefs, more of based on some, uh, it is leaving the science actually. Anyways, thank you very much.
Nice study. Like you had two groups. Like group one was controlled seizures for 1 year, and the other was uncontrolled seizures. I may have missed out on it, but did you do a subgroup analysis for these two groups, group A and B, which you had outlined earlier?
So we did not do a subgroup analysis as such, because this is, like I said, the study has just been finished, and we are still in the pipeline of doing, conducting various other analysis and methodologies. Our first priority was to get, the outcomes for all the subjects and all the patients. But as such, a subgroup analysis has not been done as yet.
Thank you, Karandeep, and thank you for the local support. We could listen to you. And to the question were very nice. And since Dr. Manjeet Tripathi is coming after returning from Odisha, and we can have a good discussion on sham aspect, which is very important. The control, sham control, what control? I think it's a very important question. It needs to be addressed in science now. Thank you, Karandeep. We can again clap for her and then go to the next.
Now, Mr. Mohammad Sharik will be presenting his work titled Effect of Yoga on Clinical Outcomes and Quality of Life in Patients with Vasovagal Syncope. Dr. Gautam Sharma is the corresponding author.
Good afternoon, everyone. Today I'm presenting a randomized controlled trial that we named Live Yoga Study, in which we have seen the effect of yoga on clinical outcomes and quality of life in patients with vasovagal syncope. So the trial was conducted at Center for Integrative Medicine and Research under the supervision of Professor in charge CIMR, Dr. Gautam Sharma. And the trial was funded by Ministry of Ayush, Government of India. So we all know that vasovagal syncope is a common faint or reflex syncope. So it's the most common form of transient loss of consciousness, in which there is a bradycardia associated and hypertension associated. So recurrent episodes of these disease actually results in poor quality of life of the patients. So although the prevalence is very high, but there are very still less treatment strategies available which do have modest efficacy, and they're largely ineffective. So yes, few studies have been done to show yoga as safe and efficacious in conditions like atrial fibrillation, myocardial infarction, and disorders including autonomic imbalances. So thinking about this, we thought of an alternative that can help in treatment of such patients. So in patients with recurrent vesical syncope, we thought if you give yoga intervention for 12 months as an adjunct to guideline-based standard therapy and compare it with only standard-based therapy, will reduce syncopal episodes and improve quality of life in these patients. Now, keeping this in mind, primary objective was to determine the impact of yoga on symptomatic burden, and secondary objective focused on the impact of yoga on quality of life and autoimmune balance. It was a single-center randomized control trial, which was conducted at CIMR for the duration of 3 years, and we kept the duration of intervention for the 1 year. Estimated sample size was 150 in each arm. And we also designed integrated yoga module by yoga physicians at CIMR, and which was further validated by yoga physicians of national repute. So the integrated module comprised mainly of postures, breathing and relaxation techniques, keeping in view the pathophysiology of PVS. Now to assess these, we had primary outcomes that was assessed as a composite of number of episodes of syncope and pre-syncope at 12 months, and secondary outcomes mainly focused on quality of life assessed by syncope functional status questionnaire and WHO BREF questionnaire scores at 12 months. Head up tilt table test negative response at 6 weeks, and heart rate variability at 6 weeks using Holter. Now we included patients aged between 15 to 70 years and who were diagnosed to have vasovagal syncope with heart positive and at least 2 episodes of syncope or pre-syncope last 3 months. We excluded patients who had accelerated hypertension and any other potent cause of syncope, including significant arrhythmias or heart failure. So we screened 270 participants, out of which 215 were excluded due to several reasons. And out of 270 participants, we were able to randomize 55 participants, 30 in intervention arm, 25 in control arm, and we followed them equally at 6 weeks, 6 months, and 12 months. And after 12 months, ITT analysis was done. So it's a beautiful flow chart that is showing the flow of the trial. We screened participants from cardiology, and after enrolling them, we randomized them in control group and intervention group. In control group, we provided them only guidelines-based therapy, which was physical counterpressure maneuvers, salt and water intake augmentation. Whereas in yoga intervention, we had yoga plus guideline-based standard therapy, and we followed them at 6 weeks, 6 months, and 12 months. So at the baseline and 6 week PSS history and examination and questionnaires, Hut and Holter, and their vasovagal episodes were assessed. And at 6 months and 12 months, only history and examination, questionnaires, and vasovagal episodes were assessed. So we wanted our participants to do yoga properly as per the module. So we wanted to train them and solve their queries. So we conducted 14 contact yoga sessions at CIMR within the first 6 months, and also advised them to practice yoga at home on regular basis, at least 5 times a week. And also at the same time, we provided yoga book to the participants for the adherence to the yoga practice at home, and also record their vasovagal syncope episodes. Now this integrated yoga module comprised mainly of breathing practices, instant relaxation techniques, and yoga asanas and pranayamas. So breathing practices actually improves venous cardiac output, and also it improves baroreceptor sensitivity. It also helps in maintaining sympathovagal balance. And whereas instant relaxation techniques helps in improving muscular tone and vascular tone, whereas asanas helps in orthostatic tolerance, and yoga asanas, they helps in relaxation. Now we come to a deep relaxation technique. It is also really important because central triggers can also cause vasovagal syncope. So it helps in blunting the central triggers, for example, anxiety and stress, and so on and so forth. Now we come to results. We can clearly make out from the figure that there was a significant reduction in mean episodes of syncope versus in intervention arm versus control arm. So we can clearly see it's a 0.7 mean episodes in intervention arm when you compare to control arm 2.52 episodes at 12 months. So we can see the impact of yoga here in the reduction of these episodes. So this is a snapshot of the impact of yoga, how powerful yoga is. At the baseline, we have seen the effect even at the baseline at 6 weeks. And from the 6 weeks to 6 months and 12 months, the flow was consistently significant. So we can see at the 12 months, there was a significant difference in reduction of vasovagal episodes in the intervention arm as compared to control arm. So interestingly, even free patient percentage were higher at all time points. So we can see it was at 6 weeks, 86.7% in intervention arm compared to only 64% in control arm. And at 6 months, it was 73% patients which were even free in intervention arm compared to 40% control arm. And again, at the 12 months, 43% of the patients were even free, as compared to 16% in control arm. So it also improved quality of life in these patients. So as assessed by SFSQ scores, all were significant along with physical health domain and psychological domain of WHO brief questionnaires. Yes, at the same time, we did not get the heart negative response as significant, and also HRE was not significant. So it was a first randomized control trial with such a long follow-up with yoga intervention in these patients. So now we can say that yoga is safe and cost-effective and efficacious intervention in the treatment strategies of these patients. So based on our findings, we postulated that positive effects of yoga in this study could be related to a multidimensional effect of this intervention, which may act through central or peripheral mechanisms, which is displayed in this diagram. So it's a pathophysiology of VVS, and we are showing that how yoga can modulate the effect of the pathways and also ultimately leading to abortion of vasovagal syncope. So if there are any peripheral triggers, so yoga can help in increasing venous return cardiac output. And similarly, that's the breathing techniques. So, and also if you have to blunt central triggers, so deep relaxation technique will help us in blunting that, ultimately leading to abortion of vasovagal syncope. In conclusion, yoga as an add-on therapy is superior to standard medical therapy alone in reducing symptomatic burden and improving quality of life in these patients. So it was published in medical journal JACC Clinical Electrophysiology in 2021. I would like to thank everyone who was associated with the trial. And the take-home message is that we should all take out time for ourselves also to perform yoga at least for some duration and take out for health. Thank you.
Thank you. Now this is open for questions and comments from the house. Okay, there's no question.
One again,
Sir.
naive question. Are there any electrophysiological or any other parameters which you can measure which are associated with the high, prevalence of syncopes?
Basically, the syncope, so unpredicted episodes of
I know,
syncope.
but some
yeah.
increasing the probability of a syncope. Let us say, is there anything? I don't know the answer myself. I'm asking.
Yes,
you
we have
to-
not explored that much so far, but yes, they could be. If we'll go into the details.
One suggestion here, you mentioned altered sympathovagal balance could have been a cause.
Yeah.
At the end, you mentioned HRV non-significant.
Yes, sir.
So I was wondering, how did you comment, or how do you verify, or how do you say? Because one of the vasovagal syncope is that sympathovagal balance, if quantified well, could help. It's not electrophysiological parameter, but it's the overall heart rate variability. So I would like to go inside the how did you actually do it? Because it appears some technical issue in this statement. I'm not able to connect the two.
Yes, sir. So I think the answer to this is that we could have done a early assessment of these investigations, although the impact has been seen in the reduction episodes, but that's not getting translated in the HRV analysis. So we could have done it 12 months or a later time point so that we could have got
More than that. You did HUTT. I think you
Yes, sir.
followed a 40 minutes protocol.
Yeah, 20, approx 40 minutes.
See, 40 minutes protocol
Yes,
is
sir.
challenging. Yeah, you can, but even a 5 minutes protocol or a latency, cardiac latency, bradycardial latency or tachycardial latency, a very good important marker just in 5 minutes.
Right, sir.
Say, how do you change your heart rate in how much time for the postural challenge? So I think there's some more technique which you can make more in-depth analysis.
Right.
Thank you. All the best.
Thanks
It's
a
a
lot.
good study.
Thanks.
Again, we can close this. Thank you.
Now I call Dr. Dushant Kumar to present his work titled Longitudinal MR Evaluation of Yoga Induced Changes in Brain in Post Stroke Recovery. Professor Ramajaya Sundar is the corresponding author.
Our respected dean sir, chairperson, faculties, and my dear friends. on the outset, I take the opportunity to thank to I take the opportunity to thanks the committee for giving the opportunity to present our work on longitudinal MR evaluation of yoga-induced changes in brain in post-stroke recovery. As per the WHO, stroke is the second leading cause of death, and post-stroke rehabilitation plays an important role in the stroke management, and conventional modality is physiotherapy. However, in the recent time, there is increasing interest in the use of yoga as a therapeutic use. The result presented in this talk is comprised of 13 patients as a part of larger longitudinal study comparing the effect of yoga and physiotherapy in brain in post-stroke rehabilitation of ischemic stroke patients. The specific objective of this study was MR-based longitudinal evaluation brain for morphometric changes using segmentation analysis, microstructural changes in cortical tracts using diffusion tensor imaging, functional changes in motor recovery by using fMRI. And other assessments were clinical score and the scores by yoga trainer and pro and anti-inflammatory cytokines measurement. I would like to highlight that to locate the motor activity, we have used fMRI, and also to study the mechanism of this plasticity. And DTIU was used to study the integrity of cortical spinal tract and as well as asymmetry of tracts. The study design comprised of first ever ischemic stroke patients who were enrolled in this study based on the compliance with the inclusion as well as exclusion criteria. And inclusion criteria, domicile in the region, NCR region was the one of the inclusion criteria. And assessment, clinical responses, MR and biochemical changes were carried out at pre-yoga, that was a baseline, that is 0 month, and post-yoga 3 and 6 months of the intervention. These were the yoga asanas which were practiced by the patients, and for this, yoga trainer visited the patient house every day, and the yoga intervention was given for 1 hour every day for 6 months. 3D-T1 and DTIU was carried out for the evaluation of the structural and microstructural changes, and EPI for fMRI was carried out. For fMRI, we have involved the unilateral and bilateral motor task of closing and opening the fist. These are the results. Clinical improvement, significant clinical improvement was observed based on the NIHS, MRS, and Barthel index results. However, the other results, the microstructural and the structural changes were not significantly improved. So therefore, we have not shown the results. And however, there are significant changes over there in the longitudinal for individual responses. So for example, let's go with this patient data. So this patient was having a left corona radiata lesion, and which are including post-lentiform nucleus also. And the affected activities were reduced motor activities in the right limb, slurred speech, reduction in the cognition and memory. So here we have mentioned the NIHS, MRS, Barthel index baseline data, and it shows that on the 3 month and 6 month, the clinical score have improved significantly. And the same was reported by the yoga trainer's observation also. The cortical thickness and cerebral white matter volume was found to be increased in these patients at 3 and 6 months in the right hemisphere. The cortical spinal tract fractional atrophy indicates that at 3 months it has increased on the which shows the compensatory mechanism, and on 6 months it was found to be decreased, and it indicates that the affected side, the left hemisphere, indicate the recovery. The total tract volume was found to be increased consistently on 3 months as well as on the 6 month. The fMRI shows the marginal increase in the affected hand at 3 months, and the 6 month, the significant increase in the affected hand was observed. This is the cortical thickness changes. So this image shows the 0 month, that's baseline, and this is a 3 month image, and this one is a difference image, and the highlighted area shows the significant changes in the brain. So there are many reasons where the brain has shown the cortical increase in the cortical thickness, and the same was observed in the 6 month also. This is a sample of segmentation statistic data, and this shows the brain region where all brain region, it shows where the gray matter and white matter changes are observed, and it goes to the 30 pages. So here we are showing only 1 pages. It just to give an idea like how use time it takes for the computation, and we are working on the automation to extract the data. This slide shows the correlation of heat map based on for the DTI-based track data and functional activity. So from here to here are the DTI-based tracks, and from here to here are the functional activity, and it shows the positive correlation with the ATR, CST, CG, forceps measure, and SLF tracts. This is a functional improvement in the bilateral motor activity. So this slide shows the functional activity in the frequency distribution domain, and this purple color shows the 0 time point, and the green 3 months, and the red is the 6 months. So on the 0 month, the purple color shows the concentrated towards the 0, it shows the no activity, and consistently on the 3 month and 6 month, it is increased to continuously. On the right hand side, on the 0 time point, also it shows the activity, and the 3 month and 6 month, progressively it was found to be increased. These are the key inferences of this study. So yoga causes measurable structural and functional changes in brain of ischemic stroke patient. Statistical significant improvement in the clinical score was observed in all the patients. Increase in functional activity in 3-week post-yoga as assessed by the yoga trainer was observed in 10 patients out of 30 patients. Increase in cortical thickness and positive change in white matter tracts was observed in 9 patients out of 13 patients. Individual responses are important and have to be studied. So this is a preliminary first report on yoga-induced structural and functional changes in stroke patients. This is the work which is in progress. So multi-resolution, multi-scale signal and image processing combined with the machine learning is going on with the IIT Bombay, and aggregate connectivity between activated ROI and rest of the brain is also in process. Dynamic thalamus cortical connectivity is we are doing it with the help of Max Planck Institute of Germany, and all these data, when it will be ready, will be put together for understanding better the effect of yoga in brain ischemic stroke patients. And I would like to acknowledge Department of Science and Technology, Government of India for financially supporting this work, and CDAC for helping us in time series data analysis. Thank you.
Any question for him? Dushyant? Yeah, Dr. Vineet.
Now that you have some good preliminary pilot data, you would like to go for a placebo-controlled trial or a standard of care arm? One arm should have standard of care, because what you're saying out here could be the natural progression in terms of improvement for most patients.
Yeah, so actually this data is the part of the study which was comprising of 2 groups. One was a physiotherapy and one was a yoga group. So that is in process to comparison. And after that, definitely there will be an advantage to go with the placebo group.
Okay, any other?
Again, if there are no more questions, any more questions? See, just a naive question. You see, you can get stroke at different areas, different locations. And I presume the effect of yoga is by activation of brain plasticity. I mean, in a very crude sense. So would, my sort of common sense tells me that different functions would be circumventable to different levels by plasticity. So is there any way by which you can sort of explore this heterogeneity? Because in this itself, when you showed your individual patients' data, there is no way of saying that whether it is the natural improvement, because even many of almost till 2 years you see some functional improvement. So the effect of yoga, how do you dissect it out in a fine manner? I mean, I think Dr. Vineet also asked this question. And in addition, there's this whole issue of, would you not like to categorize a particular kind of stroke to get a more homogeneous and studyable entity?
Yes, sir. So when we have done the group analysis, we have not found any significant changes. That was the reason. Like we are having what stroke cases we are having, that was a heterogeneous population. So it will be in future, it will be advantage to go with a homogeneous selection of the sample and proceeding for the assessment. So that will give us a better idea of the like what exactly.
Okay, thank you. Then all the best. You still have to do data with the Max Planck. You finished? Thank you.
Last but not the least, I call Dr. Sriloy Mohanty to present Dr. Rohit Bhatia's work on his behalf, titled Effect of Yoga as Add-on Therapy in Migraine. Dr. Gautam Sharma is the corresponding author.
Good afternoon, everyone. Hope you all had lunch today, because is it relevant? Yes, it is, because today, 21st June, is also the longest day of the year. And if you stay empty stomach for a longer period of time, and if you have the disease, you may get an attack. So yes, I'm talking about migraine, and this trial is the CONTAIN trial. I'll be presenting on behalf of Dr. Anand and the leading authors, Dr. Rohit Bhatia and Dr. Gautam Sharma. Migraine is one of the most commonest disabling primary headaches. It has a prevalence of around 13% globally. Migraine affects almost the whole population, especially the young and the most productive age group. Most of the absenteeism in the schools or in the office is mostly because of migraine. Even if when we know that yes, migraine is affecting so much, the treatment is still not optimally, they are not optimally treated. 50% of the participants, 50% of the patients normally say that they are not satisfied with the treatment, and around 10% of the population discontinue the medication which is allotted to them because they have side effects. So all these shortcomings gives us an opportunity to explore more about what exactly can be the other treatment strategies. Yoga, being a mind-body medicine, is everywhere like a wildfire, and the science behind it and the beneficial effect of it is now been established in many trials. In this trial, we wanted to see is if the effect of yoga as an adjuvant therapy, as a add-on to standard medical care which is given for migraine. In the hypothesis, we believe that yoga will be superior to the medical management alone when we are treating migraine. So to understand this, we planned a study, an interventional study with a probe design, which is prospective, open label, randomized, open label and blinded endpoint trial. There were two groups. One group was the control group, which took the conventional medical management, and the experimental group, which took yoga as an add-on to it, which is yoga plus the conventional medical management. In the inclusion, we included patients of between 18 to 50 years of age, having clinical migraine with or without the aura, at least 4 or at less than 14 episodes frequency of headaches per month, residing in Delhi and Delhi NCR. If they are on prophylactic medication, we made sure that there were no changes in the next 3 months, and there was no change in the last 1 month also. In the standard care, we gave risk reduction counseling, which included the lifestyle modification, appropriate sleep, regular meals, maintain relaxation, and suitable physical activities. As a prophylactic medication, propranolol was one of the most common drug which was given to the participants. Intervention was planned at CMR. First, the yoga protocol was planned, and then it was validated by yoga experts from across the country. After that, the yoga module was given. After that, the yoga module was given to the participants. We made sure that they do at least 3 sessions in a week during the study period, which is the first during the period 1 month, and the next 2 months we made sure that they do at least 5 days a week practice at home. We gave them booklets. Our co-primary objectives were the headache frequency and intensity, and the headache impact test, which is the HIT6 scores. The secondary, we wanted to see if any of these patients can be headache free. What was the medication score? Was there any reduction in the, will there be any reduction in the medicines they use? And MIDAS, which is migraine disability assessment scores. In this trial, we screened around 452 trials, and we were able to recruit only 160. Mostly our patients were excluded because they were not from the Delhi NCR area or denied consent. So 160 patients were randomizedly divided into 2 groups. As I mentioned earlier, the only standard care or yoga plus standard care group. 23 in each group were lost to follow-up. The main reason of loss to follow-up was because of work or studies. They were not able to come for the practices. At the end, 57 patients in each group completed the protocol. And at the end, we analyzed both ITT and per protocol, which is 80 for ITT and per protocol 57 in each group. In the third month, ITT, intention to treat, we saw that headache frequency, headache intensity, HIT scores, the MIDAS and pill count were reduced significantly. We saw the changes in all the scales. In the 3 months when we saw in what was seen in ITT, it was exactly same or even better in the per protocol analysis, where we did 57 in each group analysis, and we saw that all the parameters that we took, there were really good effect in the yoga group. In this, I would like to show you that in the trends of how exactly the headache frequency, headache intensity, or the HIT scores were reduced, and even the pill count were reduced. If you see the control group in the orange, there was a steady reduction, not much, but yes, there was a steady reduction, where the yoga group, from the first month itself, there was a reduction, and which continued, sustained till the last, at the third month also. Similarly, with the per protocol analysis, we saw the same results, where yoga group showed a reduction in better than the control group. In the meal delta values, when it was evaluated, there also we saw that in each and every parameters that we took, there were significant results. In the discussion, how exactly it happened, mainly yoga and pranayama, because of its beneficial effects by sympathovagal balance, or because of the muscle loosening and loosening the stiff muscles, we had the release. In the conclusion, I would like to say that yoga was superior to the medical care. 12% of the yoga group had no headache at all, where in the control group it was 0%. And secondly, it was cost effective and safe. There was no adverse event during that period. In the contain trial was published in Neurology Journal with an impact factor of 10. And later on, it was also generalized in different media and other scientific engines. Thank you.
Thank you. Thank you, Shalai. The presentation is open for questions or suggestion or comment. Dr. Vineet.
Rohit, an excellent study. I thought you said blinded outcome. So was there any blind outcome out here?
Classically, in the probe designs, we didn't use a sham yoga because that was not a part of the protocol. But the person who would randomize and person who would assign was different, and the person who would assess was completely blinded to what the patient's intervention was. As far as possible, in a scenario like this, when people come for assessment of the scales and scores, you just need to assess the score and scale rather than implementing too much into what is happening, because if they open their mouth and say, Doctor Sahab, hum yoga center gaye the, so that completely nullifies the effect. So the assessment was completely by a blinded observer who clearly did not have any understanding of the assignments of the group. And that is typically of the probe design that we always follow. We made sure as far as possible that we were completely blinded to the assigned intervention, which they were getting.
These patients, after they finished the trial, to see whether there was a lingering effect also.
So we did follow these patients. I mean, these patients still come for follow-up as well, but we did follow them up to 6 months. And some of the patients, I cannot tell you the exact proportion right now. We would not really analyze that data, but a proportion of those patients actually continue to develop that flavor for doing yoga as a part of their daily care. So probably that was difficult for me eventually to tell whether that's a continuous sustainability of the intervention which was done in the beginning, or it was a sustainability because they started practicing in their lives. you look at the whole pathophysiology of migraine, walk way back in migraine now. If we can do a study where we actually can show CPRP levels, that is something the next step. CPRP antagonist is one of the major therapies in migraine. So I think if you look at the whole pathophysiology of migraine, these people have stress, these people have day-to-day activities, they travel a lot, they don't eat well. So there's a multitude of effects that actually brings on that thing. So when Dr. Gautam and we sat down and discussed, and I really thank him for pushing this study, because he said, I'm a migraine patient and I know how bad it is to get a migraine, and if we can do something to really bring yoga into practice. So we sat down, we reviewed, and we felt that yoga is one such practice which actually relaxes you. It makes you become more calm, de-stresses you. So it really fits excellently well in migraine. And if we really talk to patients with migraine, they are either so incapacitated with the disease, and that's one of the listed major disorders for disability in WHO. So when you tell them to do something that they can, I think I see it twofold. One, that yoga is a practice that you can do at home. You don't really need to be dependent on someone. And second is that it encourages people to do some physical activity as well. Today, a lot of people, and I think there are a lot of young people here who also may be suffering from migraine with a different frequency. We have to accept that we are extremely sedentary. Getting into an exercise mode and getting to do something is not something all of us really are very, very enthusiastic about. So I think I look at that from two angles. One, that yoga may have induced that whole phenomena of relaxation, autonomic overactivity, mind being more relaxed. And second, making them indulge into something more specific for their own body every day. You talk to a lady who comes to me in the headache clinic and I ask her, आप कुछ रेगुलर कोई एक्सरसाइज करते हो? तो शी सेड, डॉक्टर साहब मैं सारा दिन घर का काम तो करती हूँ, वो तो मेरे लिए एक्सरसाइज ही है. But that's not a quality exercise that she's doing for her own self every day, the me time, what they call it. So as you rightly said, that whole profile was brought into the whole induction of the whole, this protocol was defined to bring all these components for the migraine patients. Of course, I'm not a specialist for yoga module, but we designed it, then we got it validated with some experts, and then we finally outlined it. Thank you.
Sorry, can I Rohit, after your very interesting discussion, can I have a question? The question in always, whenever you are scientifically evaluating a yoga protocol, is yoga protocol versus an alternative. See, relaxation exercises are also administered by psychologists. To the and the issue is that many times they are not, the way you rigorously administered the yoga protocol. The same way, if let us say a relaxation exercise and physiotherapy module was administered, and then we would know that yoga, one is that yoga has an effect. But the question comes in, what also came in the discussion on sham yoga, is how much of it is what we understand by yoga, which has these components which are in addition to the psychologist's relaxation exercises and the graded physiotherapy, supervised physiotherapy, and when does one start and the other one begin? So I have never.
In fact, this was an important question by the reviewer, and this paper went through intense reviews with 6 reviewers. And it took us almost 4 review sessions to answer 6 reviewers' comments to finally get into a journal like Neurology, which most of the neurologists want to get their paper in. So, sir, in migraine treatment, one thing is that you need to give time to the patient in the clinic. Number 2 is that you need to advise every patient of migraine to have some physical activity every day. In fact, I strongly believe that it's 50% pharmaceutical treatment and 50% lifestyle modification. In fact, I would say 80% lifestyle and 20% pharmaceutical treatment for some of the patients. So we, as a standard of care, we used to tell all our patients who would come to the clinic, who were a part of the study, who are not a part of the study, is that they need to have one lifestyle modification, which means stop sleeping late at the night till it is required. All youngsters sleep 2 a.m., 3 a.m. in the morning. Number 2, don't miss meals. Most of the migraine patients miss meals. That's the biggest trigger. And the third, have some physical activity. Walk half an hour, jog, play badminton, swim, whatever you want to do. So this was actually advised to all the patients. That was advised to all.
Yeah. So we're looking for the specific questions, answer to specific. Now, would you, on this basis, 80-20% advise guidelines for changing the migraine intervention? Because say 80%, 20% pharmaceuticals, 80% lifestyle. So guidelines at international level have to be changed now. To 80%? Thank you. I think we close the discussion. Thank you. It's a wonderful discussion. Thank you. Over to you.
I thank all the talented participants for presenting their amazing work and bestowing upon us such immense knowledge. And with this, we move forward to the award presentation for oral presentation and the best poster. The posters were adjudged by a panel which comprised of 7 faculty members. Dr. Neena Khanna, Dean Academics and Professor and Head of Department of Dermatology and Venerology. Dr. Padma Srivastav, Professor, Head of Department of Neurology, Chief Neurosciences Center. Dr. Praveen Vashist, Professor of Community Ophthalmology and Professor in Charge, Faculty and Recruitment Cell. Dr. Sanjeev Lalwani, Registrar and Professor, Forensic Medicine and Toxicology. Dr. Naval Kishore, Professor of Medicine and Sub-Dean Examination. Dr. K.P. Kocher, Professor, Department of Physiology. Dr. Kalpana Luthra, Professor, Department of Biochemistry. I request the Director, Sir, Dr. Neena Khanna Ma'am, Dean Academics, Dr. Subrata Sinha, Dean Research, and Dr. K.K. Deepak, Dean Examination, to present the award to the recipients. Awards will be announced first for all the oral presentations, followed by award for the poster. I call upon Dr. Surbi Gautam for her work titled as Yoga Re-establishes Immunological Tolerance and Reduces Severity of Comorbid Depression in Active Rheumatoid Arthritis. Professor Reema Dada is the corresponding author. Next, I invite Dr. S. Edmund Krista for her work titled Effect of Yoga-Based Cardiac Rehabilitation on Left Ventricular Ejection Fraction and Central Hemodynamics in Patients with Myocardial Infarction. Dr. K.K. Deepak is the corresponding author. Next, I invite Dr. Kirandeep Kaur for her work titled Effectiveness of Yoga Meditation for Adults with Epilepsy. Now I invite Mr. Mohammad Sharik for his work titled Effect of Yoga on Clinical Outcomes and Quality of Life in Patients with Vasovagal Syncope. Dr. Gautam Sharma is the corresponding author. Next is Dr. Dushyant Kumar with his work titled Longitudinal MR Evaluation of Yoga-Induced Changes in Brain in Post-Stroke Recovery. Professor Reema Jaya Sundar is the corresponding author. Now I invite Dr. Sriloy Mohanty for his work titled Effect of Yoga as Add-on Therapy in Migraine. Dr. Rohit Bhatia is the corresponding author.
I'd like to say that this is the hard work of my DM student, Dr. Anand, who's currently a faculty at BHU. This is for you, Anand. I told him to join the YouTube link. Okay.
Now I will be announcing awards for the best poster. First prize for poster goes to Dr. Vaishnavi Verma. Second prize for poster goes to Dr. Shriloy Mohanty and Dr. Nida Mir. Third prize for the poster goes to Dr. Anupama Gupta, Dr. Vidhu Dhawan, and Dr. Vandana Jain. Dr. Nida Mir, second prize for poster. Third. Third prize for poster goes to Dr. Anupama Gupta, Dr. Vidhu Dhawan, and Dr. Vandana Jain. Thank you, everyone. Now I request Dr. Renu Bhatia ma'am, Professor of Physiology, to deliver the vote of thanks.
Thank you, Monica. Good afternoon, ladies and gentlemen. It's my privilege to have been asked to propose a vote of thanks on this great occasion of celebration of 8th International Day of Yoga. I, Renu Bhatia, a member of organizing committee, on behalf of the entire committee and on my own behalf, extend a very hearty vote of thanks to the august gathering here. First of all, I would like to thank our director, Dr. Randeep Guleria, for always encouraging research in every field of our interest, be it yoga, where we explore our traditional roots, or be it the space physiology, where we want to study the unknown. So thank you, sir. I would also like to thank our Dean and Sub-Dean Research, Dean Academics, the staff of Research Section, all the judges, faculty members, staff and students for sparing their valuable time for gracing this event. The response from all the participants for the event was overwhelming, and everyone has contributed with great enthusiasm. And this is truly beyond our expectations. So the participants, they deserve a great applause. I would also like to acknowledge our gratitude to all the speakers and participants of poster session for sharing with us their research findings, and the judges, Dr. Neena Khanna, Dr. Padma Srivastava, Dr. Praveen Vashisht, Dr. Sanjeev Lalwani, Dr. Naval Kishore, Dr. KP Kochar, Dr. Kalpana Luthra for carrying out the tough task of selecting the finalists. Also to mention, an event like this does not happen overnight. The wheels start rolling way in advance, and we have been fortunate enough to be backed by a team of very proactive and dedicated members. The senior members, Dr. Subrata Sinha, Dr. KK Deepak, Dr. Vineet Ahuja, and Dr. Reema Dada, along with Dr. Rajkumar Yadav, and all the committee members for supporting and helping us at each and every step for conducting this event. I thank you, all of you. I would also like to thank the people who worked behind the scene to make this event a success. Mr. Uday, Research Section, scientists from CRU, CMET staff, a special mention to Mr. Yogesh for taking an initiative in designing, printing the posters, Horticulture Department, Engineering Section, and the conference hall staff, along with our Sulabh workers, for making this event successful. We are all happy and grateful for this successful program. With sincere feelings of gratitude, I thank you all for making this event a big success and indeed a memorable one. Thank you.
Thank you, everyone. I request you all to please join us for tea.